All right, so now we'll start lecture 25, and we're going to talk about some conditions related to transfusion medicine, such as acute blood loss, what happens when you lose a certain amount of blood. We're going to talk about blood volume replacement, okay, and how to do that. All right, so just to remember, some of the viruses that we talked about HIV, we talked about CMV, hepatitis C and B, Creutzfeldt-Jakob, we talked about the potential for bacteria. Remember, platelets are the #1 product associated with bacterial contamination, and Yersinia intolytica is usually the #1 organism that's involved in refrigerated products, all right, because it can survive at 4 degrees. We talked about some parasites, malaria, Babesia, Chagas, and Zika. Okay, so here's all your current testing, ABO, RH, including the wheat D, all right, don't forget that. Your IAT, your hepatitis B, your hepatitis C, your HIV 1 and 2, HTLV, syphilis, West Nile, CMV, and Zika. I would not be surprised if CMV is removed pretty soon, all right, just because of the prominence of leuko-reduced products. And actually, notice this note says that CMV is not an FDA requirement. So when I was in blood bank at UAMS, we used to have CMV tested units in order to transfuse our babies. However, we did correlation studies, we did literature research, and found that leukoreduction is replacing the need for CMV. So our pathologists worked with some of the techs in blood bank, and so we established a standard operating procedure that removed the requirement for CMV. And so I happen to be involved in that project. So now UAMS does no longer give CMV negative products to our babies, we give leukoreduction. All right, so we went against the AABD, but we have a study correlation, we have an established SOP that says that, so that's acceptable by the FDA. All right. All right, some other disorders requiring transfusions. Trauma or an acute blood loss, and we're going to look at what exactly happens in acute blood loss. Some coagulation disorders. Those patients that have cancer, they will often be heavily transfused as well. Bone marrow patients and other tissue transplants. Liver disease, burn patients, hemolytic anemia patients, cardiopulmonary bypass, sickle cell, and thalassemia. This is a really good overview of your most commonly transfused patients, all right? So actually, acute and chronic blood loss counts for about half of transfusions in the United States, all right? So you're involved in a trauma, motor vehicle accident, gunshot wound, anything like that, those have the potential to use a lot of blood products. Aortic aneurysms, right? So oftentimes that's a vascular case. During the surgery, you have the potential to lose a lot of blood for that too. So a little bit of the pathophysiology behind acute blood loss. The venous return, all right, during the heart determines the next heart rate, the heartbeat, all right? So if there's not enough blood, then you'll have decreased cardiac output. And what happens is your cells will not be adequately oxygenated. Therefore, you have decreased amount of ATP, which is our cell's energy source, okay? So without that ATP, then our cellular pumps won't work appropriately. The ion pump won't work in the sodium and potassium exchange. So in a normal situation, sodium slowly comes into the cells, potassium comes out, all right? However, if your ion pump is not working, sodium can come into the cell very rapidly, cause the cell to swell, and then lyse. So this is just an overview of how much blood you can lose, all right? So when you donate blood, think about how much they usually take off, right? They usually take about 500 mils, which is about, in a 150-pound person, you usually have about 5,000 mils in your circulation, all right? So that's about 10% of your total blood volume. Symptoms of that, what usually happens after you donate a unit of blood? Usually you're asymptomatic, right? You might have some lightheadedness, all right, but usually that's it, okay? If you happen to lose 20% of your blood, then you might start seeing an increased heart rate. You might get overexerted very easily, all right? And then upon going from a sitting to standing position, your blood pressure might drop, okay? If you lose 30 to 40% of your total blood volume, this would be about 1,500 mils, all right? That's when you start seeing more severe symptoms: decreased cardiac output, decreased blood pressure, rapid pulse, hard time breathing, all right, because those cells are less oxygenated, okay, and cold, clammy skin. If you lose about 40 to 50% of your blood, so that's about 2,500 mils of blood, and you have not seek treatment, then this is when you could go into volemic shock, and this could ultimately lead to death, all right? Because ultimately your oxygen carrying and your volume is decreasing, okay? And that's what happens. So some reasons for the acute bleeding: trauma, surgery, aneurysm, maybe you have an injured spleen, maybe your spleen ruptures, okay? That can be very, that's very bloody. And then OB problems. You guys remember my story, my #1 patient that used the most products in blood bank, she had placenta previa, all right? So the placenta was attached to her uterus lining. So these are your aortic aneurysms. And also when we talk about livers too. So here at UAMS, they do liver transplants. Those guys will experience heavy bleeding as well, and they'll use a lot of blood products. So if any of you guys ever work at a level 1 trauma center, your blood bank will always be very busy. But don't ever say it's quiet, all right? So if it happens to be calm and everything's going good, you sure don't say, oh, it's a quiet day today. No, don't say that, because as soon as you say that, guess what? Everything's gonna hit the fan. Yeah, you'll have a patient who has placenta previa and a liver transplant going bad, and then motor vehicle accident in the ER. It happens. Yeah, don't say slow. No. You just enjoy it. If you have that moment, you just enjoy it. Go eat lunch. I cannot tell you how many days I did not get a lunch. Okay. All right, so consequences of blood loss. We talked about decreased heart rate, decreased blood pressure. So there's insufficient pressure for the blood to travel through the arteries, all right? So then your arteries, remember, loss of volume causes those arteries to collapse. And then blood can't get back to the heart.
So it usually happens during AFib? Since it's beating so regularly.
Yeah. So then there's actually, depending on how technical you want to get, there's actually receptors that can detect this decreased pressure, and it actually will stimulate the kidney to produce epinephrine to try to stimulate the bone marrow to produce more cells, all right? But that will not happen at a quick enough rate to compensate if you're having an acute blood loss, okay? And then that epinephrine going to cause vasoconstriction. It's going to try to increase the heart rate, improve heart contraction strength as well. And then once the venous constriction, it's going to squeeze the blood from the lower extremities, all right? So it's going to try to pull blood from the extremities back to the heart, all right? That's what we need. And it's also going to pull fluid from your tissues, from your skin, and other organs, all right, to try to keep the blood oxygenated. The heart and the brain, that's what we need to stay oxygenated, all right? You're going to have increased glucose, all right? So your liver is going to be involved. Increased glucose to try to give those cells some energy as well. Kidneys are going to try to increase sodium and water reabsorption, and then again, those additional fluids by the organs. Because what's happening here, you have an acute blood loss. So you're not only losing cells, you're also losing volume, all right? So all that extra fluid is trying to replace the volume as well, to keep those vessels, the structure established, to keep them from collapsing. So your cells are going to undergo anaerobic glycolysis. You're going to have increased lactic acid. So your patient could ultimately go in acidosis. So your patient could be in metabolic acidosis, causing a right shift in your dissociation curve. And then if bleeding continues, then your brain is going to lack oxygen, okay? Which that could ultimately, that's what could lead to death. All right, so that's an overview of how serious acute blood loss is. And that's why when you present to the ER in a trauma, that's why you're the #1 priority, okay? Because it is very severe, very life-threatening. So the treatment of massive blood loss, and we've talked about our massive transfusion protocol before, 4 red cells, 4 plasma, 1 platelet, all right? That 1-to-1 volume. And one of those is because of not only do we need to give you oxygen carrying capabilities, but also replace your volume. So they might use volume expanders such as saline or Ringer's lactate. They could use colloid substance such as albumin or glucose. For blood products, it's very important we try to give them type specific. Hopefully they don't have an antibody, but if they do have an antibody, we need to give them antigen negative blood as well. In the event of a trauma, oftentimes you do not know your patient's blood type, right? So in the event you do not know that blood type, we need to give them O negative. And you will give them O negative until you have a type established on them, all right? It's very important that you guys understand, if you give a patient O negative units and then you receive the sample, whatever units were transfused without being cross-matched, you have to perform what we call a post-cross-match, all right? So once you receive that sample, you're gonna make sure those units that were transfused were compatible. You'll do your cross-match, all right? And then make sure you maintain your patient identification. So if your patient ID is unknown, so they're a John Doe, once they do get a name and medical record number, you need to make sure all of that information is updated on the blood bank side. And typically, I don't know if you guys know this, if a unknown patient presents to the ER, they assign that patient with either like a series of letters and numbers. So then it would be unknown TZ456. And then so your blood products will be labeled as that as well until they know the patient's ID, okay? So they also will use FFP. That's another reason we have that 1-to-1-to-1 ratio. They can use FFP to restore volume and maintain hemostasis. So remember, as you are losing blood, you are also losing your ability to coagulate. So the reason FFP is included in that mega pack, that's because we want to replace their volume and give them clotting ability as well. And that's why the platelets are also included in that. These are some adverse consequences of massive transfusion. I think these have really, the first two have really been reduced given the 1-to-1-to-1 ratio. All right, so we're given red cells, we're given plasma, we're given platelets. If you were to just treat massive transfusion based on red cells, you would have dilutional thrombocytopenia. All right, so the patient's platelet count is also decreasing, and then their coagulation factor concentration is also decreasing. All right, so that's why it's very important to give them all of the products in an acute blood loss situation. So if you notice a patient in the ER that they're requesting a lot of red cells on, you need to call them and say, what's going on with this patient? You guys have given him 4 red cells, and if they say he's bleeding, then number one, you might suggest they activate the massive transfusion protocol. All right, we need to give that patient some plasma as well. All right, because we are diluting out his coagulation factors and his platelets. Okay. So in blood bank, you kind of have to monitor what your patients, what kind of products they're using. And we talked about the acid-base imbalance, citrate toxicity. We've talked about this before. Remember, if your patients are receiving a lot of products in a very rapid amount of time, those products have anticoagulant in it. All right, and remember they contain citrate. That's one of our anticoagulants, CPD, CPD2, CPDA, they all have citrate in it. All right, so if they're receiving a lot of that citrate, it can bind to the calcium. All right, so that could cause them to have decreased calcium, and oftentimes they will have tingling lips. Hypothermia is another. If they're rapidly infusing products, those products are stored at refrigeration. That could cause them to go into hypothermic shock as well, that we've talked about. Immunosuppressant, and then potassium overload. All right, so these are all side effects of massive transfusion, but you have to outweigh what happens if they don't get transfused. All right, so that's kind of why I say you have to weigh your pros and cons. All right, you're going to let them bleed out, go into cardiac shock, lack of oxygen to the brain. All right, or do you let them develop hypothermia, and then you can treat that once they recover from the trauma, right? They will also probably use blood warmers too if they're transfusing at a rapid pace to combat hypothermia. Remember, I think for potassium overload, the reason that occurs, those cells, as they store, they break down. They will release potassium. So oftentimes our stored products have increased potassium. And you think about, we're rapidly transfusing, we're replacing their blood volume. So their blood in their circulation has now been replaced with the donor blood, all right? And remember that increased potassium is a risk for blood that's over 7 days. And then also, if you were transfusion whole blood, this is not really a concern now that we do component therapy, but if you were transfusing whole blood, and remember, whole blood could be used in the event of a acute blood loss situation where you need to give them all the products, all right? But that unit is stored at refrigeration. So your platelets and your granulocytes are no longer viable, all right? And then remember, factors 5 and 8 are labile. They will break down as well. So not all of your coagulation factors will be included. And we talked about this before. Remember, we talked about our anticoagulants. Must be very cautious with neonates. They need to get fresh blood. About 5 to 7 days, all right? If you don't have any fresh blood, you need to wash their products prior to transfusion. Citrate toxicity may occur, again, because that anticoagulant binds to the calcium. And we've actually talked about this before when we were talking about our blood product collection. Remember, as the cells are stored, they will lose the amount of 2,3-BPG. And remember, cells have to have 2,3-BPG in order to release their oxygen, okay? And so decreased amounts, the cells want to hold on to that oxygen. So then if the patient is transfused donor cells that has been on the shelf for a longer period of time, it usually takes about 8 hours for that 2,3-BPG to be regenerated, okay? And we talked about hypothermia. What hypothermia is going to do, the patient gets really cold. They're not going to be able to metabolize citrate. They're not going to be able to regenerate that 2,3-DPG. They're not going to be able to metabolize their drugs. They can't control that acidosis. So how we combat that is we use a blood warmer. And then we have some coagulation disorders. Coagulation disorders, 3 main categories that our patients are transfused: DIC, factors deficiencies, and platelet disorders. All right, so you guys all remember what DIC involves. The coagulation system has been activated. Patient will exhibit microclots, all right? So their platelets are going to be decreased. Their fibrinogen is going to be decreased. Their PT and PTT are going to be increased. And then thrombin is going to be rapidly created. However, what's a concern for these patients as well, given that their platelets are consumed, the coagulation factors are consumed? They can't stop bleeding, all right? So their body's throwing microclots, but they also will have bleeding tendencies as well because they don't have any available factors or platelets to stop the bleeding, okay? So DIC is known to occur in OB patients, trauma patients. We talked about some cancer that is associated with DIC, such as one of our acute myelocytic leukemias, M3 especially. And then some infections can stimulate DIC as well. And so just like I mentioned, increased PTT, PT, and then increased thrombin time too, because thrombin is continuously being generated. Decreased platelets, decreased fibrinogen, that accounts for our patient's bleeding. And then we're going to have increased fibrin split products and positive D-dimer. All right, so the treatment of DIC, number one, we want to treat the underlying condition. Is it the cancer causing the patient to go into DIC? Did they recently, for OB patients, did they deliver? The stress of that delivery caused them to go into DIC. So you want to treat the underlying condition first. These patients will probably also need transfusions because they will have bleeding tendencies. So number one, we're going to give them FFP to replace their clotting ability and platelets, all right? Anybody want to take a guess why we would want to give these patients cryoprecipitate? Anybody remember what's in your cryo? Factor 8, both the clotting portion and the von Willebrands, factor 13, and one more. It's fibrinogen, all right? Cryoprecipitate is the best concentration for fibrinogen, all right? So these patients have what? A low fibrinogen. So we could give them cryo to replace their fibrinogen, would help them improve their ability to clot, okay? So again, FFP is going to contain all of the coagulation factors. Cryo is going to contain that concentrated fibrinogen. Hemophilia A. So we could give them, remember, cryo has factor 8 in it. Hemophilia A is due to the factor 8 deficiency. And so cryo would be an appropriate therapy for them, or fresh frozen plasma. But remember, factor VIII is also one of our labile factors. So you would want to make sure that unit of fresh frozen plasma was recently thawed out, okay? These patients too are hemophiliacs with the incorporation of factor concentrates. That's more of a desired therapy for them now. And then that factor VIII concentrate could be made from pooled plasma, all right, so human derived, but the viruses have been inactivated by heat or solvents. Or it could be recombinant DNA used to make factor VIII. And then either one of these can be given at home. So the therapy for our hemophiliacs has really improved over time. And usually what happens is your factor is in a vial like this, it's lyophilized, so it's in a powder form, and then your patient has to add some type of diluent to it, and then they let it sit, they let it come to room temperature, let it sit, mix it, let it sit, and then they can draw it up in a syringe and give themselves injections. You guys might work in a blood bank where you actually are involved in determining factor doses. Here at UAMS, we used to do factor VII. So anytime our patient needed a factor VII, we had to calculate using the patient's weight. We had to calculate the dose. We would reconstitute it, and then we would issue it to the patient. So you guys might see that, you might not. I don't know how many other facilities did that. So remember, hemophilia A is factor VIII deficiency. Hemophilia B is factor IX deficiency. Mild cases of von Willebrand's are treated with DDAVP. It's a desmopressin acetate. It causes the release of factor VIII and von Willebrand's factor. And then again, factor I, who remembers what factor I is? Fibrinogen, all right? So fibrinogen is treated with cryoprecipitate. Platelets are also necessary for maintaining hemostasis. So you could have quantitative or qualitative platelet disorders that could affect your clotting ability. And you guys remember, you could have decreased production or increased destruction that would cause a decreased number. Some drugs can cause your platelets to be decreased, sepsis, liver disease. Anybody want to take a guess why liver disease causes decreased platelets? Your factors are produced, but what else is produced? What stimulates the production of platelets? Thrombopoietin, which is produced in the liver. Cardiovascular bypass surgery and primary bone marrow disorders, of course, where our megakaryocytes are. All right, and this is just a review from hematology. Quantitative test, we will always look at our platelet count, of course, blood smear evaluation for any type of giant platelets, bizarre shaped platelets, anything like that, and the bleeding time. Qualitative test, we could do platelet function studies, such as aggregation and bleeding time. So the point of platelets is for the patient to be able to adequately stop bleeding, right? So you can measure the success of platelets by the platelet count, all right? We should see an increase in their platelet count. And then also the patients should be able to stop the bleeding. And this is all review. We've talked about these before. You have your random platelets. This is for platelets that come from a whole blood collection and the platelets are pulled off. And remember, that is not considered a therapeutic dose. And so usually to reach the level of therapeutic dose, we would pull about 6 to 10 donors together. So pull all of their platelets to reach that therapeutic dose, all right? Versus the apheresis technique, where we can get a therapeutic dose of platelets from one single donor, okay?
We wait to do the apheresis to see if the patient's refractory, or
Typically what might happen, so if you gave random platelets and their platelet count didn't come up, you might try a single donor apheresis unit and see how they respond to that. If they're still refractory, then they probably either have some type of platelet antibody or HLA antibody that's attacking those platelets, and then those platelets are being destroyed by the spleen. And then, so we've talked about HLA matched platelets. We also talked about cross-matched platelets. So if your patient is refractory, they might need specialty platelets. And just as we have a designated hemoglobin before we transfuse our patient's red cells, there's usually also a platelet threshold as well. Some facilities might have it at 20,000 per microliter. Some might even have it as low as 10,000 per microliter before the patient will receive platelet transfusions. Because what happens if your platelet count is that low? You're susceptible to spontaneous bleeding, right? I mean, even like a little paper cut won't stop bleeding, all right, if your platelet count is that low. And you guys remember 1 unit of platelet concentrate should increase your platelet count by 5,000, and each platelet unit should contain 5.5 times 10 to the 10th platelets. And then we have our cancer treatment. These patients will receive a lot of transfusions as well because the treatment they are undergoing, such as chemotherapy, will cause them to have decreased white cell counts, red cell count, and platelet count. It completely wipes out their cells. So a huge concern for these, if they have a low white cell count, the ability to fight off infections, the low red cell count, their ability for oxygen carrying capabilities, and then of course their platelets is the ability to stop with bleeding. It's very important that bone marrow transplant patients, and also probably because they have a cancer diagnosis, they are considered immunocompromised. So they need to get leukodepleted products and irradiated products. We want to try to reduce the exposure to any HLA antigens and also reduce their risk for graft versus host disease. You guys remember graft versus host disease is very hard to treat once it occurs, and is especially immunocompromised patients won't be able to survive from it, okay? You guys probably all know in bone marrow transplants, and we will talk about this in our HLA lecture, bone marrow transplants, given an HLA matched bone marrow transplant is more important than an ABO compatible bone marrow transplant. So it is possible that an O patient could receive a bone marrow transplant from an A donor, okay? What's gonna happen is those A stem cells will start producing A red cells in your O patient. So your type after a bone marrow transplant might change, all right? And so we have a future lecture where we will talk about how blood bank handles that. How do we transfuse those patients, okay? We'll talk about that.
Do not still have A antibodies? They're type O.
So remember, a good theory behind that is these guys are immunocompromised, so their production of antibodies also decreases as well. So they will have some, and they might have some initial hemolysis occurring, but then once those donor cells start producing, they will be accepted, all right? And then liver disease, all right? So the liver is very vascular. A lot of problems can arise from the liver. You'll have decreased platelet count. You'll have decreased synthesis of your clotting factors, right? All of your clotting factors are produced in the liver. Acute blood loss from the esophageal varices, all right? So that's your vessels within the liver, okay? And then nutritional problems, iron and folate deficiency. FFP and platelets. These guys will probably, if you have liver disease, have a liver transplant, anything like that, these guys will be heavily transfused, all right? FFP to replace the coagulation factors, platelets to boost their platelet count. And like I mentioned, liver transplants, these guys will use a lot of products during and immediately following the surgery. Burn patients can have increased vascular permeability. Fluid and protein can escape the tissues. Symptoms are actually very similar to what happens in acute blood loss. The patient could lose fluids and red cells. The patients are susceptible to electrolyte imbalances and infections. Any of you guys ever know somebody that was a burn patient? They receive a lot of fluids, all right? So they're gonna replace their volume. Usually they try to give them saline or crystalloid fluid. Or Ringer's lactate is what I meant to say. Often on these patients too, they might be transfused red cells. And then why? Because what happens to the red cells in burn patients? The cells are hemolyzed. And then even a granulocyte, a buffy coat might be warranted in these patients. And we will talk about our autoimmune hemolytic anemia patients later too. Blood bank, if you have a patient that has autoimmune hemolytic anemia, that means they have an autoantibody that is attacking cells. We will not recommend transfusion for these patients, okay? We will only recommend transfusion if absolutely necessary. Number one, it's very hard for us to identify any underlying antibodies, right? And number two, it's very hard to find compatible units due to that autoantibody, all right? And remember, we have warm and cold reacting autoantibodies. The cold reacting autoantibody is not as big of a deal because we can use a blood warmer during the transfusion, but the warm autoantibody, probably that antibody will attack the donor cells, so then that transfusion is not safe for your recipient, nor will it do any good, all right? However, we can make that recommendation, but a lot of times clinicians will decide to transfuse anyway. All right, and then the cardiopulmonary bypass, this is actually the cardio, Sarah's group project is a warm auto patient. If any of you guys know anybody that's had cardiopulmonary bypass surgery, part of that procedure involves them being hooked up to a pump. And so during the procedure, their blood is circulated through that pump to help oxygenate it because they're actually working on the heart. There's some side effects from using that instrument as well. Hemostasis is altered from the effects of heparin given to the patient. Platelet function that can be altered, and the decreased platelet counts. All right, and then we all know about our sickle cell and thalassemia patients. Thalassemia major and sickle cell patients get transfused throughout their lifetime. One of the side effects is iron overload, so they will have iron chelation as well. They will also be alloimmunized, meaning that they will probably build multiple antibodies. There is a kind of standard operating procedure in place now where when a patient is diagnosed with sickle cell, we try to establish a baseline phenotype on them, and we try to give them phenotypically matched red cells to prevent them from building red cell antigens. However, if you don't have that baseline phenotype, a lot of these sickle cell patients have already built these antibodies. So that's something in place. A lot of blood banks will practice that, especially if you don't do a complete phenotype, they will do RH and KALE at least to try to prevent the building of those antibodies. A huge concern for sickle cell patients if they are ever scheduled for surgery. A lot of them will have what we call hypertransfusion, so they might be transfused ahead of their schedule, ahead of their surgery, and that is just to try to reduce the amount of hemoglobin S and increase the amount of normal hemoglobin A, so they don't, to lower the amount of bleeding during surgery. And neocytes as well might be useful too. So neocytes are younger cells, so they will remain in their circulation longer. We can try to give fresh cells. We will definitely try to remove white cells. So the leukoreduce to prevent HLA alloimmunization again, because these patients are transfused so much. And like I mentioned, try to phenotype and give antigen negative blood. All right, that is lecture 25. Sarah, I'll email you. All right, you guys have any questions? You guys have chemistry today, right?